Marilyn Priel. Welcome to the better part. Going from the depths of despair to the heights of sometimes an out-of-control excitement can be debilitating, mentally and physically, for people suffering from bipolar disorder. Neuropsychiatrist Dr. Saad Shakir will explain this condition, commonly called manic depression. Stay with us. Besides his specialty of neuropsychiatry, Dr. Shakir has studied and worked in a number of medical fields. This has given him an amazing background in health issues. For many years, he has been chosen by his peers, patients, and pharmaceutical companies as, quote, best doctor in Silicon Valley. Welcome, Dr. Shakir.
Thank you, Marilyn. It's a pleasure to be with you here again. I always look forward to these meetings.
Well, thank you. Now, the last time you were here, we talked about the types of depression, and you explained that it takes different forms sometimes, and we even covered the anxiety. And there's another form of depression that are manic depression. So would you tell us what is considered manic?
I think it's a great question you're raising. So you can approach it from a depression point of view, or you really can look at it as a bipolar spectrum. Because oftentimes people don't really know they're bipolar early on. They go to doctors. Usually depression is what drives them to get help. And then when they fail treatment, we say, well, what are we missing? Are they having some periods of mania or hypomania? And I'll define that in a minute. And oftentimes patients are not troubled by their mild highs. As a matter of fact, many people like it. So when we're doing an evaluation, we always ask to bring in a significant other or a parent if they're a teenager, because that's the person who will really tell you that there are periods where they're not depressed. They are very high, sometimes in a positive way, very creative, high energy, feeling they need less sleep. They're coming out with projects. That's called hypomania, which is a mild high. That's really not a source of problem for a lot of people. As a matter of fact, I joke about it and say in Silicon Valley, that's the superstar of companies. You know, it's like they have meals in the electronic companies. They work 16, 18 hours a day. But if you suspect that person has bipolar, ask their spouse, what does Joe do when he comes home? Oh, he drives me crazy. He's irritable, he's angry, he drinks too much, he can't sleep. But during the day, they might be having high energy. So that's hypomania. Mania is a more severe form where people have a disruption in their ability to function. And it's not always positive feeling. Sometimes it is. They feel euphoria, they feel special connectedness and superpowers. But sometimes it's rage, irritability, short-temperedness, loss of control, aggression, violence. 20 to 30% of people who go through a manic episode have psychotic symptoms. They can have hallucinations and delusions. But that's when the severe case of mania breaks through. And that person it's a medical emergency. Once a person, so by American Psychiatric Association criteria, to diagnose bipolar, there are different types of bipolar, but bipolar 1. So to meet criteria for bipolar 1, you have to have a history of 1 week minimum of mania or 4 days of severe symptoms requiring hospitalization. So taking a detailed history is really important, and sometimes the person will not tell you that, but somebody who knows them does. There's bipolar 2. Bipolar 2 is mostly depression, but somewhere in their history, they have brief periods of hypomania, the milder version. Maybe more creativity. Sometimes it can cause them trouble, you know, like employment issues. Maybe they're short-tempered, they have a hard time getting along with others. So the point of it is we really need to take a detailed longitudinal history. There is a condition called cyclothymia. Cyclothymia is like a very mild mood swings that does not break through in severe states and unlikely to cause clinically significant syndrome, but it can disrupt marriages and relationships, trust. People can be more likely to be unfaithful in their relationships, and they can use substance abuse. I know I went on a detailed, but I think it's important to recognize no two people are exactly alike, and we need to take a good history from the individual, as well as somebody who knows them longitudinally. It's very hard to make a diagnosis in one visit. So I often have people bring in their life history, and as you get to know them, you'll be able to review the diagnosis and redefine it later on.
Sometimes people tend to go on a gambling episode or a spending episode, different things like that. Is that manic, part of manic?
A bipolar illness is a medical condition. It has biological, psychological, behavioral situation, and oftentimes has what's called comorbidities, which is coexisting conditions with it. If someone is going, I'll give you actually a good example. I once had a patient who, years ago, who was bipolar, and he came in only when he's depressed. Until I suspect, and he was not responding to antidepressant. So one visit, I brought his wife in. And his wife looked at him and says, John, I'm going to call him John. John, did you tell him what happens when you're not depressed? He says, no, that's not important because it doesn't bother me. So I said, go ahead, Jane, describe to me what happened. So he drives me crazy. When he's not depressed, he wants to drive to Tahoe, no matter what time of day it is, gamble for 24 to 48 hours, drink too much, is irritable, angry, and doesn't sleep. So there was the clue. And this is a person who had failed multiple trials of antidepressant treatment. So we made the diagnosis of bipolar. So I think, and so talking about gambling, in this case, he gambled only when he was in a manic state. However, I mentioned comorbidities earlier. It's not, actually one of the commonest coexisting condition with bipolar is anxiety, all kinds of anxiety, OCD, hoarding, personality disorders, impulsivity, ADHD. So gambling can be a comorbid condition. Addictive behavior is very high. That's what I was getting. So either anxiety disorders are very high or substance abuse or use disorders. So gambling can be sometimes regarded as a compulsive habit that bipolars go through, but somebody can have a gambling addiction unrelated to bipolar. So I want to make sure we don't lump everybody in the same basket. So.
And we hear about shopaholics, people who just shop and buy things they don't need and run up their credit card until they're in deep trouble.
I'll give you an example where it is a medical condition. I have a patient who hates to go to stores. The only time she is impulsive in her compulsive buying is when she's in a manic state. She goes and spends a lot of money on things she does not need. So that's very atypical. Most people who like shopping and buy things and change them, and all. Those people don't necessarily have a bipolar disorder. So the bipolar disorder is during the manic phase. There could be impairment in judgment about financial decisions or impulsivity related to buying.
What about promiscuity?
So in the mania criteria, so by the way, there is a good screening questionnaire that's available on the public domain that has been developed in the past 20 years. It's called MDQ, which stands for Mood Disorder Questionnaire. It has 3 questions. The first question has 13 symptoms. So let me go see how good my memory is. So racing thoughts, distractibility, impulsivity, poor attention, impulsive shopping and spending, promiscuity, high powers, feeling some superpowers, increased libido, impulse decision, we talked about that. That's question 1. Question 2 is whether those symptoms coexist together. Because if you look at the teenager, many teenagers have high libido or this or that, but the coexistence is important if the answer is yes. The third is, does that cause them impairment? None to severe. If it's moderate to severe. So if someone has 7 or more, +2, +3, then that meets the criteria. So I want to make sure that the person looks at the whole issue to make the diagnosis.
It can sound a little bit like ADHD in a way.
So they go hand in hand. So depending on when you catch it. I'll start with childhood, okay? And I'll give you an example. I have a family of actually 3 generations under my care. 3 older brothers are my patients, and mom and dad are. So the youngest of the 4, a few years ago, was having difficulty at school. He was 6 years old. And I was on vacation. He went to the pediatrician because the teacher said, Johnny can't concentrate and focus. I think he has ADHD. Could you evaluate him? So a well-intentioned pediatrician met with them for a few minutes, says, yeah, maybe he's ADHD. Here's stimulant medication, which is often used. Thank God this was Friday, and thank God I was in the office back on Monday. Monday, midday, I get a crisis call from mom, who's my patient. Help. Johnny, I just got a call from the school nurse. He beat up 3 kids, and he is rageful, and the school says we can't handle him, come and take him. So I saw him on an emergency basis. He has a bipolar, and a lot of family members are bipolar, but he had not been diagnosed before. I had not seen him before. So he also has ADHD symptoms. So the wrong diagnosis here triggered him into an agitated, aggressive state. And in a way, it made my job easy to diagnose him, and Johnny is doing fabulously 3 years later now. So they can go hand in hand. So if you're a parent looking at a child with ADHD, how is it different if they're bipolar? They usually don't respond well to the classical way of treating ADHD, which we talked about in an earlier series, medication, psychotherapy. However, if somebody does have a bipolar gene, they might not manifest fully until adolescence. So oftentimes, if you look at a bipolar diagnosis, most of the time it's easy to diagnose between 15 and 25. But if somebody has ADHD and bipolar, those are the ones that are symptomatic earlier. And how do you make the distinction? Their ADHD symptoms are there, but they have more aggressive tendencies. It's cyclical. They have very severe rage episodes. Temper tantrums can be severe. If I see a child or a young adolescent with severe depression, that is almost always a flag that we should look whether this person is developing bipolar tendencies. It's very common to present that way. The reason why it's important to know what you're doing is the example I mentioned. If you give them the wrong medication, and also oftentimes teenagers are told that they have depression, here's Prozac-like or Zoloft-like medication, and then I get a call a week later that they are beating somebody up and they're manic, because you can induce mania if you're bipolar. So
from the antidepressant
from
medicine.
Antidepressants, from stimulants, from substance abuse. So it's really important to have a holistic evaluation that...
Can we look at the brain? Because before you showed us, it was the right front lobe, I think, that affected the ADHD. And does that also, is that the area where the depression and manic areas would be, if you'd show us?
So thanks for asking. So I brought a model of the brain here. So if you look at, this is the front, this is the back. This is called the cerebellum, which is the balance center of the brain. The mood and focus issues of the brain are right and left, prefrontal area. So if you look at a line in the middle, this is where the motor cortex controls movement. So all the area in front of that is billions of synapses connected. So if we open that area, which I'm going to do here, so the prefrontal area, so this area, the top layer, is the executive center of the brain, where decisions are made, where if someone is ADHD, they might have difficulty with executive function or difficulty with follow-through. A lot of ADHD, as we talk, they have brilliant ideas, but when it comes to follow-through, it's not good. So it's usually a disruption in the executive center. If you look at deeper in the prefrontal cortex, you have an area just surrounding the pink area here, as you see, called the limbic system of the brain, which goes around these are the ventricles of the brain. So if you look at the hippocampus, the amygdala, hypothalamus, so these areas are wired to control and react to emotionality. So the amygdala is a small part of the brain, but that's the emotional center. I call it the thermostat of the brain. If somebody had a trauma experience, it can light up. So really it's important to know that they are all connected and they talk to each other. This area is called the orbitofrontal cortex. So it's all wired to connect. So nowadays, I want to add this in because we want to get away from labels. Because labels really don't describe what's going on. So in my teaching to doctors and neuroscientists, I tell them which circuits in the brain are implicated. Because the same circuits can be disrupted in focus issues, impulsivity, but they also can be disrupted during a phase of a bipolar crisis. So we start treating circuits and different clusters of functions and the relationship to mental illness.
Is there an area for creativity?
The right side of the brain. So again, this is an old classification, but I'll mention it because people hear it all the time. The left dominance is the analytic part of the brain. It's the, it's the engineer, it's the mathematician, it's the calculating part of the brain.
Logic.
The creative center of the brain is regarded to be the right prefrontal cortex. So this is where people come up with some great ideas, artistic expressions. Some of the famous historical artists who had mental illness, Van Gogh and others, Beethoven, had a very well-developed right brain. But there was dysfunction in the left brain, what I call the brakes of the operation. In other words, they can be very creative, but they might have poor judgment sometimes when they go through cycles. So my advice is to look at the brain being an important part of emotional and mental issues. But where, what, and when is evolving as we know more about the science in the brain.
I was wondering about now the frequency of you talked about the ups and downs of the bipolar and everything. How frequent will people be depressed and then go to be manic? Was it like 1 week depressed and 1 week manic, or some people will do it throughout the same day, don't they?
Well, you see me smiling, right?
Yes.
Yeah, because I still have to find an exact definition that fits every person. So let me tell you in general how we approach that. The classical bipolar 1, they do have some cycles where if you have a week or more of mania, and as long as episodic depression, that meets criteria for bipolar 1. But there's really no rhyme or reason. Some people can have depression all of their life. Some people can have it for 6 to 9 months. There was a 13-year study by the National Institute of Mental Health on bipolar patients. Without treatment, they wanted to see what percentage of the time they were in what phase of mood. So in bipolar 1, they noticed that, and this is a rough approximation, about 50% of the time of bipolar 1 without treatment were in a normal mood, which is called euthymia. So it could be you, me, could be the next person on the board of directors. They're creative, usually very smart people. About 40% of the mood time, it was depression. These are bipolar 1, which is mania is an issue. Only about 9% of the time, there was mania or hypomania tendencies. But it's that small percentage that gets them in trouble. That's when they end up in a hospital or doing something outrageous. However, depression in a bipolar is a challenge to treat because those are the ones who end up going to the doctor when they're depressed and they get the wrong medication and they get worse. So, but interesting, the disability in a bipolar 1. They did a similar study 13 and a half years on bipolar 2, and the numbers are even more confusing. Less than 2% of the time they had hypomania. Those people never had a full mania, but 2%, and that could be rage or irritability. Depression was about 45% of the time, and euthymia was about 50% of the time.
Now there's something called mixed.
So let me talk about that because I was going to get to that. So there's also 2 other labels I want to put on the table here. Mixed mania is usually someone who's very common, who's been in treatment. They have features of mania, they have features of depression intertwined. That's called mixed episodes bipolar, and they're actually common. What do you do with them? Do you put them on antidepressant? So that's common. The other very, very, very common is what's called rapid cycling bipolar. Kids, when they have bipolar, oftentimes by definition are rapid cyclers. They can be in a great mood and creative one day, and then they might be contemplating suicide when they break up with a girlfriend or something, teenagers. And a lot of times adults with bipolar who have rapid cyclings are the ones who've been seeing doctors for a long time and getting antidepressants alone. Antidepressants can fuel rapid cycling more rapidly. A couple more things I want to mention. Women. Women who have postpartum depression. Of course, postpartum depression is common, but sometimes postpartum depression, if it's repeated, can be associated with bipolar in the future. So when we take a history of a woman who's had 2 prior episodes following childbirth, it's a flag that we should screen them for bipolar also.
And regular medicines like cold medicines and allergy medicines, do they affect that in any way and bring on a manic phase?
So let me expand on your question. Can chemicals affect mood? The answer is absolutely. So let me tell you, in a good intake, we should really look at everything, including over-the-counter, including herbal things. Sometimes people take too much caffeine. So a lot of prescription medications, as good as they are, can have impact on destabilizing moods.
And what about sleeping and actual food? Are there certain foods that people might be allergic to that would cause something?
Amazing. Great, Marilyn. Sleep is a big issue in 2 ways. Sleep deprivation can cause a syndrome similar to bipolar. Years ago when I worked in an emergency room, I get somebody coming in and they look psychotic, manic, and when I take a history, they haven't slept for 3-4 days. Sleep is recovery. Healthy, quantity and quality. So we'll talk about that in another series. But bipolar individuals are particularly susceptible to sleep deprivation. I have some of my patients who are stable and they travel different time zones. I always urge them to have a mechanism to deal with insomnia, because if they go 1 or 2 nights on the road in Japan or wherever they're traveling, it can trigger a manic episode. So we become very religious to emphasize sleep. But there's also another side to it. If someone is manic, they have diminished need of sleep, they think they have superpowers. So sleep is almost always a trigger, but also a symptom of mania. Food, so food itself might affect it, but I think alcohol. Let me bring alcohol and substance abuse. A lot of times people who have bipolar illness self-medicate. Chemicals alter the mood. So we're very careful in addressing that issue. Food, we emphasize how, what, when, and how, and what you eat. So frequent smaller meals from a medical point of view is healthier. Hypoglycemia can trigger, so if you go a long time without eating, a drop in blood sugar for susceptible individuals can trigger, I mean, we all can relate to that when you become irritable or if you're having caffeine withdrawal. So very important to recognize these are important things. But 2 other things I want to bring up which are very important here. One is hormones. Hormones are a very important issue when it comes to mood disorders. In women, like PMS symptoms, I have some women who only have bipolar symptoms 2 to 5 days before their menstrual cycle, yet they have a strong family history of bipolar, and the rest of the cycle they're fine, because hormonal shifts can affect and trigger. The other big issue that we know a lot about now is seasonal. There's an area in the brain called the suprachiasmatic nucleus, where the light going through the eye activates and balances wakefulness. So bipolars, bringing back to bipolars, bipolar individuals can have different relationship to seasonality. So you ready for this? Depression in a bipolar is very common in the winter, fall and winter months when the days are shorter. But mania is extremely common in the spring and summer. April actually is a very common month, and this is one reason why suicide rates are higher, because they might be dormant and stagnant in the winter and they get mixed episodes in the spring. Energy is high, and if they are not treated appropriately, it might go in the wrong direction. So yeah, light, the effect of light is important. As a matter of fact, light therapy is approved adjunct to seasonal depressive disorders.
So one of the things, or 2 of the things that you do, you do the testing of the genes to find out if the family genetics, if they have a maybe a possibility of developing one of these conditions, and you also do brain mapping. Does that help diagnose these things?
So let me address the genetics first. There's a new field now that the reliable science behind it is what's called pharmacogenetics. It's not knowing who's going to develop. It's not like, you know, the BRCA gene in breast cancer where you can predict, or the Alzheimer's gene. This is more predicting how you respond to medical interventions, because everything we take orally, medicinally, is metabolized through the liver. Now there are some scientific tests how the liver breaks down those medication, and we can't assume everybody is wired the same way based on their genetic and how they process medication. Clinically, those of you in the clinical medicine know sometimes you give the same medicine to 3 people. One has a great result, one has miserable results, one has tons of side effects. And now we know that we can do a genetic study. So it's a DNA test we do in my office, where we take a swab from inside of the cheek, and it will tell us the main mechanisms of how their body metabolizes, not just psychiatric medication, but pain medications, ADHD, folic acid. So it is really amazing. It's the science behind the science. It's like in the past we just do trial and error. Now we can do more educated trials and error. So that's where genes are helping in my field. Now the brain mapping is a different direction. So the brain mapping is elaborating on what I showed you here, is what can we learn about the brain function and physiology in mental illness. So EEG, electroencephalogram, is used a lot by neurologists if someone has a stroke or a seizure. We have now other ways to study the behavioral aspect of the brain, the areas I showed you. We have a test called quantitative EEG, QEEG. Well, we put a cap on your head, it has 20 leads. It's simple words, the hot spots and the cold spots in the brain. If you have autism, if you have impulsivity, if you have bipolar. So it adds another dimension. Let me caution you, because I don't want your audience to think, oh, that's the only way we make a diagnosis. We don't use it as a front diagnostic tools for a variety of reasons, including cost, including reliability. But it's a good secondary or tertiary diagnostic tool. Clinical diagnosis remains the best, but this would really be helpful, especially if you have a child who is both having bipolar features, ADHD, obsession, hoarding. QEEG is fantastic, because one of our interpreters of the QEEG is the founder of neurofeedback in QEEG, and he gives you a detailed report saying this person will do well with this approach. So it is amazing how much we can use science.
Well, that's very exciting, and thank you for explaining all this to us.
You're welcome.
And I look forward to your next visit.
I always look forward to coming back and talking to you and your colleagues and your audience. Thank you so much.
Thank you. Thank you for joining us. We always love it when you do. Please come again and watch our many other interesting and informative programs. Goodbye for now.